And I will start sharing my screen. All right, everybody able to see my slideshow? Or somebody?
Yep.
Yes.
Yeah.
Perfect. All right. So again, tonight we're going to touch on some stuff that I feel is the hardest for people to understand when it comes to cardiology. And again, I teach the nurses at the college. I teach new residents at the college, so new physicians. I do refresher classes for physicians that maybe don't work in emergency medicine or cardiology. So it's okay to not fully understand things. There's literally doctors out there that fully don't understand what a rhythm looks like. I've had physicians before that I put them through class, and I bring up a cardiac arrest rhythm, and they have no idea what to do. Don't be that person. Us as paramedics should know exactly what to do. We are the masters of disaster. We are the people that you know people lean on when they call 911. We are the ones that they expect to show up at their door and have every single answer. Doesn't matter if we know it or not. They want us to know that we either have it or we know where to find it. So the first thing we're going to kind of review tonight, we're going to go over heart blocks again. Um, you know, the one thing that I ask paramedic students all the time, even from last classes, is what did you feel you needed more work on during cardiology? And the big thing was heart blocks. It's easy to tell somebody's got elevation. It's easy to tell somebody's got depression, especially now with you guys being able to determine that. And you should be looking at 12 leads now and keeping track of them either in the ER or whatever clinical unit you're in, as well as your field times. Start printing them off and keeping a copy of them. I understand the ER can look at you a little funny when you're asking for a copy of the 12 lead because a lot of it has patient information. But just have them black it out or cut that portion off, and that way you can keep it and look back on it. So the blocks that really concern us: first degree AV block, second degree type 1, also known as a Winky block, second degree type 2, also known as Mobitz 2, and a third degree AV block. Remember, first and second degree type 1, those are low grade. What that means is that they don't really might not have an effect on some patients. They can be easily treated with atropine. When we talk about like second degree type 2 and third degree, those are a little more severe. Those are the patients that heart rates are in the 20s or in the 30s, and we could potentially have to begin pacing them. And I've got a good example of a patient that I paced 5 years ago, maybe 4 years ago. I've got a rhythm strip on here that I'll show you guys and run through with you. So looking at our first degree AV block, without reading that stuff on top, tell me in layman's terms what a first degree block is. What am I looking at? Somebody.
The P to R interval is widened or prolonged.
Okay, so my interval from my P wave to my uh, Q wave, my PR interval, right, is prolonged, and it's consistently prolonged, right? It doesn't change. It stays the same through all my complexes. Is this still a regular rhythm?
Yes.
Okay, so let's talk about potential signs and symptoms of this. If it's a low grade, when I mean low grade is not severe, what are some potential signs and symptoms that I could see of somebody with a first degree block?
Altered mental status,
Okay,
low blood pressure.
okay, so I'll put AMS. We could potentially see hypotension, but it generally won't because we're still getting a ventricular beat. If they are hypotensive, it's probably due to something else. But we'll go ahead and put that on there. And these are the patients that could be calling about something else, something totally different from any sort of cardiac condition. These are the patients that could be complaining of abdominal pain, right? But since they're having abdominal pain, we do a 12 lead on them. And we notice, hey, they have a first degree block. It's common. People have it. It's not deadly. It's just delayed conduction from the SA node down through the rest of the heart. Think of, a construction zone where you have a construction worker on each side of the road. They have that slow sign that rotates back and forth that like says stop on one side, slow down on the other. All this is a block that's being slowed down going down that road. That's all it is. It's an impulse that had to slow down more than it wanted to. It's somewhere between my SA node and my ventricles, right? And what I'm looking at here again is distance, is time. So it's just taking more time getting down there. That's why my PR interval is extended. Again, really common with patients. You can see this pretty regularly with people. Don't freak out about it unless they are symptomatic. And again, treat your patient, not your monitor. Treat the patient's symptoms, not what you're seeing on the monitor. I can have a monitor screaming at me saying STEMI or saying bundle branch block or that my patient's dying, and my patient can be looking at me saying, is everything okay? Don't rely just based off technology. Use your assessment of your patients. All right, second degree type 1, without looking at anything up here. Somebody tell me what this is.
Pauses.
What was that?
A pause.
Okay, so, yeah, we could say there's a pause. Is it regular or irregular?
It is. It's actually regular.
Are you sure?
Irregular, not the same.
Irregular. Why? And why is it irregular?
Well, they're all
It
marching around except for
progressively
the one
gets
drop.
longer.
Okay, so they technically don't all march out. This one and this one have the same distance, but from here to here is a lot longer. So that'd be an irregular rhythm. So what's happening to my PR interval?
It's getting longer with every beat.
Okay, it's getting longer with every beat, right? Until what?
It drops the QRS complex.
Until I drop this circle part. There's nothing there, right? So I have a PR interval. We'll label that 1. We'll label this one 2. We'll label this one 3. And we'll label my drop complex 4. So number 1, my PR interval, how many boxes is that roughly?
2.
Think it starts at the beginning of the P wave. So 4 roughly. So 0.16. That's within normal limits. There's no issues there. What about number 2? How many boxes are we thinking there? I count about 8. So 8 times 0.04 gives me 0.32. Okay, that's well outside the normal limits. What about number 3?
10.
Okay, so 0.40, well outside normal limits. And what about number 4? Do I even have a PR interval?
No.
No, it's literally just progressive lengthening. I have a PR interval that's short, then it gets a little bit longer, then it gets a little bit longer, and then it just drops entirely because my conduction at some point, that block got so severe that my impulse wasn't able to make it through. So we'll label this 1 because that's my normal PR interval. 2, it got a little bit longer. 3, longer yet. 4, because I'm dropping a complex. See how there's no activity down here? And then we start back over at 1. Longer drop, then you have a winky block. We're referring to the PR interval. With this poem or this song, we're always looking at the PR interval. Okay, second degree type 2. First of all, regular or irregular?
Irregular.
Okay, so I'm going to put an I for irregular. What's happening here? I mean, what are my PR intervals doing?
You're missing your QRSs in 2 spots.
Okay. Well, what about my PR intervals? What about 1
I'm
and
trying
2?
to count it, sorry.
1 and 2 and 3 and 4 over here. What do we notice about the PR interval there?
They're all about the same.
More
They're all
P
about the
waves than
same.
Q waves.
Okay, so more P waves than Q waves. Where I have 1, 2, 3, and 4 there, are they within normal limits?
Yeah.
Yeah. So a second degree type 2 is literally more P waves than more QRS complexes. Whoever said that, good job. I have a normal PR interval when it's there. I'm just dropping a complex, right? Every now and then. Makes it an irregular rhythm. Second degree type 1s and second degree type 2s are generally the only blocks that are irregular. First degree and third degree are generally regular rhythms. Second degree type 2, again, atropine might not work on this because atropine works by stopping what nerve?
Mm,
The vagus nerve?
The vagus nerve, right? What does the vagus nerve do? If I tell somebody I want them to bear down or I want them to vagal out, what am I doing to their heart rate?
I'm trying to decrease it by
slowing
vaguing
it
down.
Okay, I'm trying to decrease their heart rate. Atropine works by not letting us do that. That's literally how the drug works. Is it goes in and displaces the vagus nerve so it can no longer have an effect on the heart. The vagus nerve is the brake for the heart. If we disable the brakes on a car, what happens? It won't stop, right? It won't slow down. Same thing with our heart. Think of our brakes as the vagus nerve. And atropine is somebody coming along and cutting our brake lines. Same concept. It's the same way it works. Third degree block. This is the worst one of them all. Why is that? What do I see here?
You're seeing extra P's.
Okay, I'm still seeing more P waves and QRSs. Somebody else had something in there too.
There's no correlation in the QRSs.
Okay, there's no correlation between my P wave and my QRS complexes. The top of my heart is not talking to the bottom. For some reason, there is a blockage between my SA node and my ventricles, a complete blockage. It's not letting the impulse get through. My P waves are all equal distance from each other. So I've got one here, there, 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 there. And there's going to be one buried in here, my guess, because they're all equal distance from each other. I can guess where the next P wave is going to be. Is this regular or irregular?
irregular.
Are you sure?
It's
Look at my
regular.
R to R interval.
It's regular.
It is regular. Third degree blocks will generally appear regular. So atropine might not work on this either. In this third degree blocks, think about it. If this is a 6-second strip, 1 dash, 2 dash, 3 dash, what's my heart rate?
30.
30.
30.
Around 30, right? What do the ventricles fire at?
20 to 40.
20 to 40. Falls right inside that realm. Because my atrium, my SA node is no longer the primary pacemaker. That block is so severe that the ventricles have now taken over. And they say, hey, we're going to take over, but we're a lot slower. We only fire at 20 to 40. That's why patients in a third degree block will generally have a heart rate between 20 and 40. What's our treatment for this? And I told students today, I
Synchronized
look
pacing.
at pacing, right? I look at stability with my patients. The two things I look at, does anybody remember from me saying from the other class? And if you were in the class this morning, don't say anything. Do you remember what I said I look at for stability?
Blood pressure and mental status.
Okay, blood pressure and mental status, right? Because I got to have perfusion to mentate. I have to have perfusion for my brain to work properly. If my patient is stable, I treat them with meds, such as atropine. But atropine is probably not going to work here. If a patient's stable in third degree block, just transport them. You don't have to intervene. Treat their symptoms. Maybe they're nauseous. If they're unstable, how do I treat this? Tanya, you said we pace them. Who agrees with
Yes.
that?
Yes.
I'd agree with that. Where's my Let me find a picture here real quick that I want to show you guys. Of a patient in this rhythm. All right, can you guys see that?
Yes. No, not really.
It's kind of blurry, right?
Mm-hmm.
Can you at least make out this bottom 12 lead somewhat? Oh God, where'd it go?
Yeah.
Can you see like 1, 2, 3, AVR, AVL, AVF, V1,
Yep.
V2, V3?
Yeah.
Okay, so I'm gonna draw some stuff on here so it looks a little bit easier. So this bottom one, and you guys have probably heard me tell you this scenario before. This was an 80-year-old female that I had. She was unresponsive. Literally, I mean, we thought she was trending cardiac arrest because her heart rate was in the 20s initially when we got to her. I mean, if you look at that 12 lead down there, I've got one bead per lead, right? Now, I'm going to zoom in or see if I can zoom in on V1 here. Can you guys see V1 at all? Can you see that line? Like the isoelectric line?
Yep.
Do you see those small little P waves?
Yes.
Let me zoom in. Does anybody not see that? Let me zoom out and draw them real quick, and then I'll zoom back in on it. Okay. Above or right below each one of those red marks, there's a P wave. You can kind of make out those little humps. That was the only lead that I could look at on this whole 12 lead. I looked at that and said, oh my God, this patient's in a 3rd degree block. I couldn't see it anywhere else besides one lead. But what do I notice about my P waves?
Equal.
They're equal distance from each other. And I'm guaranteeing there's one hidden in that tall T wave. They're equal distance from each other. This is a textbook 3rd degree block. And you can see I wrote up there, patient unresponsive and initial heart rate was 24. We paced her at a rate of 60 beats per minute. The patient immediately regained consciousness. So let's zoom in at that top one. What do you notice of this 4 lead? What do you see in front of each QRS complex?
Pacer spike?
Yeah, I was pacing her. That's my pacemaker initiating an impulse because you have a QRS right behind it, right? That's the ultimate treatment with these patients that are having a 3rd degree block. They're not always going to be conscious. They might be unconscious, and you've got to figure out what's going on. I went down my perfect assessment. I checked a blood sugar first. I asked about medical history. This patient actually ended up overdosing on metoprolol that caused a permanent 3rd degree heart block. Initially, her blood pressure was in the 80s. Can anybody see what her blood pressure is up there at the top if I circle it? After pacing, what did her blood pressure come up to?
163 over 116.
163 over 116. Massive change in blood pressure, right? And this was honestly probably, I don't know, the second person I'd ever paced in my whole paramedic career. But it was knowing to recognize, hey, that's a 3rd degree block. Those P waves are perfectly equal distance from each other. And I can show you guys this in person. It's a little bit easier to look at. But you can see them textbook. I mean, completely textbook. Those P waves are perfectly equal distance from each other. Now, in her case, I was able to pace her, no issue, right? I had a patient about a month ago that heart rate was in the 20s. We could not get her to pace. I mean, I could not get the monitor to line up correctly. to capture and
We have a
initiate
question
pacers.
for you.
Yeah,
So when you pace her, are you gonna start at 60 or 70 on her?
wherever you want to start.
Okay,
My monitor defaulted at 60, so I went with that.
okay. Thank you.
My patient that I had a month ago, I couldn't get her to pace. I couldn't get it to capture. So literally, I watched her heart rate come down from the 20s into the 10s, 15, 16. So I said, hey, she's crashing. Let's just start CPR. We coded her after 2 rounds of epi. We got her back at a sustainable heart rate in the 60s. No idea what caused it. I have no idea what caused it, but it's knowing how to perform your assessment, how to treat your patient based off what's happening. Let me go back up to the top here. All right, another form block, bundle branch blocks. Who remembers what lead I said we look at for bundle branch blocks?
V1.
V1. We look at lead V1. We don't pay attention to anything else. When we look at a 12 lead, we look at V1. Now, to be a block, I don't care if it's a right bundle branch or a left bundle branch, what does that QRS complex have to be?
Wide.
Yeah, it has to be greater than 0.12. It has to be wide. And when I say what is a narrow complex versus a wide complex, you shouldn't have to measure that. You can look at it and tell if it's wide. If it's narrow, it's a narrow QRS. If it's wide, it's a really fat looking QRS. You should be able to just look at that right off the bat and say narrow or wide. So, what's a concern with bundle branch blocks? I mean, what could we potentially see symptom wise with our patients?
Can't they kind of mimic a STEMI?
They can. It can be an imposter of STEMI, but symptom wise, not sign, symptom. What are they telling me? If I have a block of some sort that comes out of nowhere and takes a little bit longer to get to the bottom of my heart, could I potentially be dizzy? Could I potentially feel like my heart's skipping a beat?
Yes.
Could I have maybe a quick reduction in blood pressure? Potentially. And these patients can also have a fainting spell. This is one thing to consider is patients that have passed out and regained consciousness really quickly. One thing that always comes to my mind is some sort of cardiac condition. We should be doing 12 leads on all those patients. Do we? No. But should we? Yes. So some of the causes of a left bundle branch block. Okay. Congestive heart failure can cause a block. It can be benign. It can be idiopathic, unknown origin. Could be some sort of electrical occurrence within the heart. Could be congenital. So if I'm looking at lead V1, I don't want you to pay attention to this down here. Let me look at that. Lead V1. How do I know that's a left bundle branch block? I mean, it's wide, right?
Pointing down.
Okay, pointing down. I'll go with that. What's an easy way that I can tell as well?
If it goes left.
Yeah, if I'm going backwards and I get to this J point, remember our J points where we start to change directions? Which way do I have to turn? I have to turn left, right? It's wide and I have to turn left. That is a left bundle branch block. It can sometimes look like a W. If it looks like a W, I want you to remember something. So everybody sees that W there. W is for William. William has 2 L's left. Okay. Just an easy way. You might have it look like a W. It might not look like a W. It might look just like that picture there. but it's still wide. Now, is a left bundle branch block a diagnosis? No. It's an anomaly. It's something we can see on a patient's 12 lead. Now, is that something I'm looking for right off the bat? No. Initially, what am I looking for on a 12 lead? When I'm performing a 12 lead, what am I initially looking for?
ST elevation or depression.
I'm looking for lines that go up, or I'm looking for lines that go down. ST elevation or ST depression. Okay. How do I know that this is a right bundle branch block?
It goes up.
Aha. So if I'm coming down backwards, coming to my J point, which way do I have to turn? I have to turn right. And it's wide. Okay, that's a right bundle. It can also look like this. What letter does that look like?
An M.
Yeah, it looks like an M. So if it looks like that and you have a notch like that, remember this. William for left, Morrow for right. Easiest way is to see if it goes up or down. If the majority of the QRS is up, it's a right. If the majority of the QRS is down, it's a left. How do we treat bundle branch blocks? Without even looking at that, how do we treat them?
Treat the patient.
That's the exact answer I'm looking for. We can't treat bundle branch blocks. We have no way of treating them. Treat your patient. You will hear me say that about I don't know how many medical conditions. Treat your patient. If your patient is Brady and unresponsive and unstable, what do? We could potentially pace these patients, right? But that's not because of that. That's because of a slow heart rate. Okay, ST elevation with our 12 lead. Does anybody remember what the parts are of a 12 lead and what leads look at what? I know I had you take a picture of it. So let me call on somebody. Hey, Sarah, can you tell me what one
Yes.
AVL, V5, and V6 refer to? What part of the heart?
Lateral.
Lateral. Good. Okay. Let's see. Scott Watson, you there? I think he was having fun.
Yes.
Okay, you there. 2-3 and AVF. What part of the heart am I looking at with 2-3 and AVF?
You are looking at inferior.
Bingo, inferior. Shane leads V3 and V4. What am I looking at?
You're looking at an anterior.
Anterior. I love this. You guys are answering this. Okay, and then somebody at random, I don't care who it is, V1 and V2.
Septal.
Septal. Awesome. So how many millimeters of elevation should I have before I'm looking at calling a STEMI?
1.
1 in green.
1.
Okay, greater than 1, right? So let's look at this 12 lead here. I know it's kind of foggy. I know it isn't the best. Again, pick your own way to look through them. I start at 1 and move in this direction because I can look at 1, 2, 3 at the same time as I'm going in a diagonal, but you can go straight up and down. It doesn't matter. What do we see? Where do we potentially see elevation?
You're seeing it in V2 and V6? No, V3.
V what?
V1, V2, and V3, you could see it when it's going down.
Okay. Anywhere else?
I'm still looking. 6.
I don't see it in
Put on
6.
6, 4. I'm sorry. 1.
There,
There,
I'll
4.
zoom in.
Sorry. You're seeing it in 1, 2, 3, 4.
Okay. Would anybody concur with that or say anything different?
I would say 5.
Okay. Maybe a millimeter if we're lucky to call it a millimeter in 5. And the same thing in V1. It looks a lot like elevation, but I'm not sure truly how elevated that is. But where I'm really seeing major elevation is V2, V3, V4, right? Now, what part of the heart am I referring to there?
Anterior and septal.
Yeah, so anteroseptal, right? Do I have any reciprocal changes? And remember, reciprocal changes if I see depression in any other leads. Do you see that anywhere?
2, 3, and AVF.
Yeah, I've got it starting in 2, 3, and AVF. Where else?
V6.
V6, I'd agree with that. Yeah, so this is a patient having an anteroseptal MI, right? Elevation's easy to tell. You guys got this part nailed it. I'm glad I had you guys take a picture of it. It is important for you to memorize this because unfortunately you won't have that picture when you're taking a test or, well, my test you will, but when you're taking the National Registry test, you won't have that available to you. It is very important you remember this. Not so much which artery it's looking at. There's only 3 leads that I care about which artery they're looking at. Any guess which 3 those are?
The right coronary artery.
2, 3, and AVF. I'm concerned about a right-sided MI, right? So let's see if we can find one of those. Oh, look, here we go. So, elevation, we're at Mr. Klumpner.
2 through AVF.
Okay. 2 through AVF. Do you see depression anywhere?
AVL. And maybe a little bit in LV1. Maybe just a little. It's kind of harder to see on my computer.
Okay. What about V2? Does anybody see it in V2 through V4?
Yep.
No.
What lead did I say I can move over? If I have elevation 2, 3, and AVF, what lead did I say to move over to the opposite side of the chest?
V4.
Move
lead 4.
over
1.
and relabel it. And then I'm looking for elevation in that lead, right? Remember, where I have elevation on the opposite side of the heart, I should have depression. That's how reciprocal changes work.
Down.
If you look here, I've got elevation. On the opposite side of the heart, I have depression. Mr. Robinson, where do you see elevation?
Hold on, I'm driving, but I'll look here.
Nice job, fella.
Yeah. I see it before.
Sorry. Okay. Mr.
Before V5 and V6. Sorry.
Jesus, don't get in an accident. Pay attention to the road. Mr. Fulton, where do you see it? I heard you on here earlier. I know you're here. Maybe not.
What are you looking for?
Oh, he's not responding, so it's fine. Tanya, what actually you can tell me. Where do I see elevation? Where do you see elevation?
V4.
Okay.
I don't know, V6 maybe.
Okay, I see it there too. Where else?
Well, this looks so different. Hold on a second. I see some in, well, I don't know, C1, the P wave is so close. It almost the very first P wave. 3 and AVF.
Okay, 3 in AVF, maybe a little bit in 2. I've got widespread elevation if I really look at it.
Yeah.
I've got elevation in 2, 3 AVF, V3, V4, V5, V6. And I've got depression in what leads? Somebody.
ABL.
Okay, I've got depression in AVL. Where else?
V2.
1.
V2, 1. Yeah. So is that reciprocal change? Do I have depression where I have elevation? I have elevation in some of the leads and I have depression in some of the other ones. Absolutely, that's reciprocal change. When it comes to right-sided MIs, 40%, around 40, actually, I think the numbers changed. I think it's around 47% of right-sided MIs involve the right ventricle. What I'm saying is that they can be caused still by the left coronary artery. That's why we move V4 over to see if it's truly a right coronary artery involvement. 3 to 8% of those are true right coronary artery involvements. Just looking at 2, 3, and AVF, I'm looking at the left artery. The second I move V4 over, I start to look at the right. Think if this was my, let me play devil's advocate here. This heart on the left, if I had V1, V2, V3, V4, V5, V6, I take V4 and I move it to the exact same place on the other side. Which artery am I now looking at? Which artery is that lead looking at now?
Right corner.
Yeah, it's looking at the right side. Hence why we do that. You can, if you want, move all your leads over and reverse it. But me personally, I don't want to waste the time. I just move V4. You don't have to move all of them. And here's a perfect example. We have elevation 2, 3 in AVF. Okay, we decide to move V4 over. Look down here. What do you now see in what they labeled V4 on?
Elevation.
I see elevation. So what's that tell me?
The right-sided MI.
Heck yes, that is 100% confirmation that's a right-sided MI. What do I want to be careful in giving this patient?
Nitro.
Nitro,
Why?
because the preload.
Increases preload.
Nate, you're answering a lot of questions while you're driving. God help you. Explain to me, I'm a brand new EMT. Explain to me why I can't give nitro to somebody having chest pain. Explain this to me.
You're going to bottom out their blood pressure.
Okay. Why? All brand new
Because it
EMTs, that's
decreases
why.
the preload.
Decrease preload. Okay. Why?
You're
Why is my
dilating
preload
everything.
decreased? I'm dilating everything, right? I went from a vessel that's this big with this much fluid to a vessel that's that big. I didn't change the fluid. I just changed the container size. So I have less pressure. That's our concern with vasodilating patients. We have less blood coming into the heart. Who in here knows a little bit about cars? Who in here is a car person? everybody should be able to answer this next question. If you're driving a car, you should know this next question. What happens to an engine if I don't put oil in it?
It fries,
It dies.
crashes.
Weird. What happens to the heart if I don't allow blood to come into it?
Stops.
It's the exact same thing. All right. We're going to jump into something called axis deviation, but first I want you guys to take a 5-minute break. We'll come back at 6:52 and we'll jump into something new for us. All right. I'm going to introduce you guys to something called axis deviation. And we determine this by looking at 12 lead. Does it change our treatment? No. Does it change how we do what we do with the first patient? No. But it tells us which way blood could be flowing better, or which way electrical current, which side of the heart electrical current is flowing better through. So think of, if I have a line, let me get my pen back out. If I have a line, I don't know why it's not drawing, right here, and that's perfectly even. If my axis deviated towards the left, that means it's more pulling to the left. Would you agree? As opposed to the right? Would anybody agree with that? If it's going more towards the left, there's a reason for it. So that could be called left axis deviation. If it's going more towards the right, I would call that right axis deviation. Now, let me draw a potato heart, as I call it, because I suck at drawing hearts. I have my node there. I have a node here. Breaks off into these bundle branches. All right. This is the right side of my heart. This is the left. If I have, let's say, a bundle branch block on the right side, so right here I have a blockage, which way do you think the electrical current's going to travel more towards?
The left.
Yeah, I mean, if I'm driving down a road and I see that there's an accident up ahead that's stopping the road, I'm going to find a different route. It's the same thing with our heart. If I had a blockage here instead of on the right, which way would it go towards then?
To the right.
Okay, to the right. So I could call that right axis deviation. What we're looking at is what side of the heart is better perfusing. So let me ask you this. I have elevation in leads 2, 3, and AVF, which is potentially the right side of the heart. Which way is the electrical current in the blood going to go more towards if I have an injury on that side?
The left.
It's going to go more towards the left because the right side of the heart isn't functioning properly. It's the same said if the left side of the heart's having issues, electricity and blood will better flow towards the right side. Remember that blood and electricity flow towards the better perfused and more healthy side of the heart. It's just common nature, even for us. If I'm walking down a hallway and there's 3 doors in front of me and one of the doors is open, we want to take the path of least resistance as humans. We go through the door that's already open. Same thing with our heart. It finds the path of least resistance and takes it. So if there's any sort of blockage or any sort of infarction or muscle loss, it will stay away from that because it knows it's going to have to work harder. It's lazy. It doesn't want to do that. It wants to take the road less traveled or the road more traveled. I want everybody to put their thumbs in front of them right now. Put your hands out in front of you. Put your thumbs up. Your left thumb is lead 1. Your right thumb is lead AVF. Okay. So 2 thumbs up means normal access. And this is, I'm looking at leads 1 and AVF. Normal access. That means that both sides of the heart are perfusing good. That's why I have 2 thumbs up. I want you to take your left thumb and turn it upside down. Turn your left hand upside down with your thumb still out. Which side of the heart now has good access?
The right side.
The right side. My left is a thumbs down. My right is still a thumbs up. that I look at lead 1 and AVF. Lead 1 is my left hand, lead AVF is my right. So if I have a negative complex in lead 1 and a positive complex in lead AVF, that's right axis deviation. And I'll show you here shortly. So normal axis, right? 2 thumbs up. Keep your thumbs out. Lead 1, left thumbs up. Lead AVF, right thumbs up. See how both the complexes are positive? Okay, left axis deviation. Blood and electricity is flowing better towards the left side of the heart. Keep your thumbs out in front of you. In your left hand, you should have a thumbs up because lead 1 is up. Look at lead AVF. What should my thumb be doing now on the right side?
Moving down.
Okay, so what do I do with my right hand?
Put it down.
Yeah.
Or it comes down.
Thumbs down, right? So I have a thumbs up on which hand?
Left, so you're perfusing better to the left.
Yeah, so I have left axis deviation. Again, does this mean anything? And not potentially, but if somebody's having an MI or somebody has a block and you see axis deviation, it's just another way of confirming it. Now, let's see. Cassie, are you on here?
Yes.
Don't be hesitant, it's fine. You sounded terrified. Okay, so hold your thumbs up in front of you.
Okay.
I can just picture everybody in here with the thumbs up. It's great. If I had right axis deviation, if blood is flowing more towards the right, what is my right hand going to do with my thumb?
I don't know. I missed your thumb thing. I started
Okay.
it and my dogs got into something.
No, you're
and
fine. Two
I
thumbs up.
missed you. I
Two-
dropped my daughter off the base.
Both the thumbs up in front of you.
Sorry.
Okay, they're both up.
Look at lead AVF here. Okay.
Yep.
What do you
Okay.
notice about that complex? More positive or more negative?
It's going down, so deviation.
Okay, so turn your right hand, because your right hand is AVF, turn it upside down. Turn your thumb down.
Okay,
Look at lead 1. More positive or more negative?
positive.
Okay, so leave that thumbs up.
Okay,
The hand that you have the thumbs up is where you have axis deviation.
okay.
So which hand?
Left.
Boom. That's how you tell axis deviation.
Okay.
Let's look at a different one. Lead 1 is down. Lead AVF is up. Somebody tell me what that is.
AVF would be your axis.
Do what?
AVF would be your axis, right?
But which side of the heart? What side of the heart is that? Which thumb is that?
Left.
The right.
Yeah, AVF is always my right thumb.
Yeah, right.
Lead 1 is always my left thumb.
Okay.
So if AVF is positive, it looks like a thumbs up. Lead 1 looks like a thumbs down.
Right.
So I have which side is still thumbs up with my hands? Which side?
Right.
Yeah, so I have right axis deviation.
Cool.
And that's just in determining which side of the heart is better perfused. That's all it is. And the reason I teach you this is because you might have questions about axis deviation. And all it is again, which side of the heart is better perfused? Put your thumbs in front of you and look at 1 in AVF. That's literally, I remember taking my national history and I had a question about axis deviation, and I felt like an idiot because I sat there with my thumbs in front of me and was like, okay, lead 1 is down. I turned my thumb upside down, and lead AVF is up. So I have right axis deviation because my right thumb's up. Now, there are instances where we have 2 thumbs down, 1 in AVF. This can indicate a couple things. Either A, you have an electrical impulse that is weak, or you have a heart that is sick. Now, looking at this 12 lead, if I take axis deviation out of it, do I see anything on that 12 lead that scares me?
No.
No, I don't either. Don't let axis deviation be the only thing that freaks you. If you see nothing else in that 12 lead, axis deviation doesn't matter. There's nothing, literally, I'm not going to call a hospital and say, hey, Doc, we got problems. This guy has left axis deviation. He will laugh in my face and hang up on me. He doesn't care. It's just for us as paramedics to be like, hey, you know what? The blood is and electricity are going more towards the left side of the heart. Potentially there's a problem on the right side. Why do we care? It just tells us which side of the heart is better perfused. That's it. All right, so I'm going to throw some scenarios at you guys. And I want you to, God, I wonder if I can do, no, I can't. I will pick a person at random and we will talk through it, okay? Case number 1. This is a 59-year-old adult male. Chief complaint of chest pain. Onset 2 hours prior to being seen. No medical history. He currently takes metoprolol and nitroglycerin, along with metformin. Funny. What do those meds treat? And this is a perfect example. Somebody claims they have no medical history, but yet they're on medications. That happens. We have to look at the meds and know what those meds treat and then ask them about it. So let's start with metoprolol. Okay, beta blocker, right? I feel like you had that today.
We did.
What happens? What do we know about somebody that's prescribed nitro?
They have angina.
Angina.
They've had some sort of chest pain in the past, right? Okay. And the other thing you can think of is that it's usually a safe bet if they have nitro. They're generally not have a problem with the right side of their heart. Metformin, what does that treat?
Type 2 diabetes for high blood sugar.
Treats diabetes, right? So based off those medications, what can I tell about this guy?
History of diabetes and some kind of cardiac history. We know he has angina, and for some reason he's on a beta blocker, so we can assume he had some kind of hypertension issue.
Okay, so literally those 3 meds. If I read those, I would ask him, be like, "Hey, do you have and I won't say diabetes, because have you ever had a patient that you're like, okay, so you're diabetic, and they say, no, I'm not. I just have problems with my sugar. You ever had a patient like that? I for some reason I get them all the time. Just ask them in clear terms. Hey, do you have problems with your blood sugar? Break it down in easy ways for them to remember it. Hey, do you have any heart problems? Do you have a family history of heart problems? Do you normally have high blood pressure? Because people think that since they're on the medications, that the condition doesn't exist anymore. All right, allergies, none. Pain radiates to his left arm, and he is a smoker. What risk factors do we have here for a cardiac event?
You could
So
have
he's diabetic.
hypertensive crisis, MIs.
Okay. So he's got a history of hypertension. He has some sort of cardiac history where his nitro. What else? What does diabetes do to blood vessels over time? If uncontrolled.
It lack of perfusion.
No. What is sugar? What does D50 do to blood vessels?
Oh, it's acidic, so it kind of weakens them.
It weakens your blood vessels, right? Diabetes does the same thing. It's an increased amount of sugar. How about the fact that
would you be at like risk for? Sorry.
Yeah.
Would you be at risk for AAA?
No, don't look that far into it. Just classify it as potential cardiac issues because of that.
Okay.
How about the fact that he's a male? How about the fact that his pain radiates to his left arm? How about the fact that he's a smoker? These are all risk factors for somebody having a cardiac event. You perform 12 lead on your patient. This is what you get. Mr. Klempner, you're on a roll. Tell me what you see.
ST elevation and AVL needs 1. And I'm just reading these. I would say very minor ST depression in V3. Oh wait, I'm reading these. Yeah, the one pointing down. Leads 3 also have ST depression. And we got depression in V1.
Okay,
Elevation in V2.
Elevation? Or
No. Depression.
there you go.
Yeah, sorry, the blurred.
Do you see elevation anywhere else?
V4, V5.
Okay, V4, not so much. That's just the tall T wave, right?
Okay.
Because
V5.
if I was to draw this out,
V5.
V5, I got it. Okay. Maybe minute V6, maybe a millimeter. What leads have elevation?
1
Your
AVL.
septal wall.
Nope. Nope. Sorry.
Collateral.
My lateral leads, right?
Yeah.
They all go in line with each other. 1 AVL, V5, and V6. Do I have depression in other leads? Do I have reciprocal change?
Yeah.
Absolutely, I do. So how are you treating this guy? You get him in the back of your ambulance. What do you want to do?
Aspirin at 324 milligrams. Nitro if he's having chest pain, or if it's in our protocols. Ours generally, you treat these kind of issues with nitro and aspirin unless you have a contraindication.
Okay.
Mona.
I wouldn't really do anything else depending on if he was stable or not. I'd probably get 2 IVs going and I guess saline hung just in case he rapidly deteriorated.
Okay.
I'd have pads and airway management tools ready at least, and then just kind of be ready for him to tank. But if he's not symptomatic or there's nothing else that need treated, I'd just leave him be and monitor him actively with serial 12 leads.
That's exactly what I'd do. Maybe I'd give fentanyl if his pain persists. But that's the exact same treatment I do.
Or morphine if his blood pressure can handle it, right?
Morphine.
Isn't that
Yeah, absolutely.
ideal for? Yeah. Okay.
Yep, I agree.
Do they still use the Mona thing for chest pain or no?
Yes, but the problem is that people get stuck on Mona and it's not in the correct order.
Okay.
Because if you say Mona, like if somebody says that during national registry testing, I'll fail them.
I just always I do aspirin, nitro, and then maybe morphine later. You know,
Okay,
just.
but do you always put patients on oxygen? They're having an MI.
Not really, but sometimes it comforts them.
Okay, but remember, in cardiac patients, oxygen can actually be harmful.
That's true. Got it. Sorry.
So aspirin, nitro, it's almost the opposite. Aspirin, nitro, morphine. I mean, Mona is to remember your treatments, but don't get in the habit of saying that because that indicates that that's the path that you would treat them in. All right. Let's see. Who else do I have on here? Mr. Graham.
Yes.
You guys sound so thrilled when I call on you. Like, why can't you be like Jeopardy or something and like jumping up and down, or Wheel of Fortune? All right. 82-year-old female, chief complaint unresponsive. Onset found by son, medical history diabetes, medications metoprolol, metformin. allergic to penicillin, no radiation, social history unknown. Talk to me, Goose.
Um,
There was a little high pitch there.
yeah.
Is it fast or slow?
It's slow.
Okay.
And looks it looks like we have more P's than we do QRSs.
Okay. Let's say heart rate is 32.
Okay.
Is it regular?
Um,
To the best of your knowledge.
to the best of my knowledge, yes.
Okay. Now look down at lead 2, because lead 2 is a really identifying lead.
Okay.
What do you notice about your P waves?
They look like they're getting longer.
Okay. But am I dropping anything?
Yes.
Where?
Um, it looks like you're dropping a QRS towards the end.
Okay, it kind of does look like I'm dropping towards the end. But what that is that this is actually a QRS starting right here, but
Oh.
it cuts off. So let me do this. Would this change it if I did this for you?
Yes.
Those are all my P waves. What do you notice about them?
They all don't have QRSs.
Well, that was a heck of an observation. What do you notice about them? Are they regular or irregular?
Oh, hang on. They look regular.
Okay. Do they look like they line up with my QRSs?
Yes.
Andrew, you're gonna be the death of me, son.
I'm sorry. I'm trying, man. I'm trying. All right.
No, it's fine. Okay. The distance from my P waves,
Yeah.
does it all look about the same?
Yeah.
Okay. We know we're some sort of block, right?
Right.
We have to figure out which one. Remember, second degree blocks are both irregular.
Yeah.
First degree and third degree are regular.
Yeah.
So first degree has a PR interval that's long and stays long.
Yep.
Generally, heart rate isn't affected. Third degree has no correlation between P waves and QRSs,
Uh-huh.
and our heart rate's between 20 and 40.
So my first when I first looked at it, my first assumption was that it was a third degree.
Okay. And you're not wrong to go with your gut instinct. When you start to second guess yourself is when you'll get in trouble. Literally, all you have to do is look at my P waves at the bottom and say, are they equal distance from each other?
Yeah.
And am I not dropping complexes? If so, third degree block. How do we treat this lady? She's unresponsive.
You can pace her.
Yeah, heck yes, I can. That's exactly what I would do. All right. Gosh, I need to find somebody I haven't picked on yet. Who hasn't gotten the wrath? How about Joel?
Yep.
All right, 44-year-old adult male. Problem, middle-aged male. Risk factor. Chief complaint, feels like his heart's racing. Started 24 hours ago before he called. Medical history, all he knows is that he has some cardiac problems. He takes amiodarone. That should be a big clue right there. He is allergic to latex and codeine. Doesn't really have any pain. It doesn't radiate anywhere. And he's actually a really athletic person. So, based off what we know there, I want you to keep amiodarone in your mind. That's his med. This is what we see.
I'm going to call that VTAC.
And you would be 100% correct. People will get confused and go, oh my God, I need to look at lead 1, 2, 3, AVR, AVL, AVF. Identify the rhythm first. Look down here. Lead 2. It's wide and it's fast. That is textbook VTAC. Plus, what medication does he take?
Amiodarone.
Amiodarone. How do we treat this if this guy's stable? There's 2 routes we can take. We can monitor and transport, or we can give a med. What med can we give him?
150 milligrams amiodarone.
150 milligrams of amiodarone in a drip generally. Or you can just push the 150 slowly. Say this guy was unstable. How would I treat him? Still has a pulse, but he's unstable.
Cardioversion.
Absolutely. Good job. Shane, walk me through this one.
Okay.
24-year-old female. For one, a 24-year-old female. Okay. Chief complaint, shortness or chest pain with shortness of breath. Onset 30 minutes ago. Medical history, she has anxiety, depression. She takes alprazolam and escitalopram. She's allergic to epinephrine. She said it radiates all over her chest, and she recently broke up with her boyfriend. Right off the bat, what are you thinking?
Anxiety attack.
Okay, why do you say that?
History of anxiety. She's on benzos, and she's got chest pain all over. She recently went through a hard time in her life with a recent breakup.
Okay. I want to point something out here too. Do you think that that's true?
I'd be pretty surprised to know that she's had epinephrine at 24 years old.
Well, here's the thing too. Epinephrine is in our body already. It's adrenaline. It's norepi. I've literally had a patient tell me they were allergic to epinephrine, and I just stared at them because I had to question myself if that's a thing or not. That's a natural hormone in the body. That's a BS allergy. Okay, 12 lead. What do we see?
I'm not seeing anything really jumping out at me yet.
Okay, nothing's jumping out at you. Let me throw some vitals at you, okay? Heart rate, we'll say 120. BP, 130 over 90. O2, 91%. Respiratory rate, 30. End tidal, 22. What are her vitals telling me?
She's breathing too fast. She's
Okay.
locked up. Her heart rate's fast. She might be hyperventilating a bit, which is why her O2 sats are a little low, and her end tidal is 22.
Perfect. What's treatment for this patient?
Coach her on her breathing.
This is one of those patients where honestly, us being a paramedic might not help, but us being human might. This is somebody that you just have to sit next to and kind of calm down. Hey, tell me what's going on. These are also the patients that are going to have, it'll feel like their arms and legs are tingling because of the reduced buildup of carbon dioxide. They're blowing too much of it off. They can get what's called carpal pedal spasms, where their arms and hands will tingle because they're hyperventilating. We go on this call more often than not.
But you can't blow her off right away.
No,
Assuming she's
absolutely.
not having a heart attack, though.
No. But we have to also look at the signs and symptoms. And this is what I'm saying, like literally sit beside your patient if you can. I love sitting beside my patients if I can, because it brings me to their level. I don't like standing above them. I don't want them to feel like insecure or inferior or anything. I'll literally sit beside a patient on a couch and just sit there and talk to them. And this is one of those instances where I'm probably going to sit and talk to her and be like, hey, how long has this been going on? Another important question to ask is, has this happened before? I can tell you, I've seen some pretty severe anxiety attacks. I mean, to the point that we've had to medicate the person. It can potentially be an emergency. Can I rule out a heart history or heart problems? No, I can't. One thing I told one of your fellow students yesterday on the phone, I had a cardiologist tell me this. If you ask somebody where their chest pain is and they can point to it with one finger, it's probably not cardiac. If you ask where their chest pain is and they use their hand and kind of motion over their whole chest, it's probably cardiac. Cardiac pain is crushing. It's dull. It feels like there's weight on your chest, like you can't breathe. Sharp pain generally isn't cardiac. All right. Let's see. Mr. Watson, I'm going to pick on you again, buddy. Just know the next lecture I won't pick on anybody that I called out in this lecture. You there? Can you hear me? Yes, no, maybe so. All right. Let's try someone else. Mr. Leach, are you on here?
Yep.
All right, buddy. God, I love your guys' answers. It's enthusiastic. 55-year-old male. Chief complaint. He had a fainting spell. He had a syncopal episode, okay? Onset 20 minutes ago. He has a history of high blood pressure. He's not currently on any medications. No need to be. His blood pressure is not that out of control. He is allergic to certain pain meds, which is a thing. Social history, nothing out of the ordinary. This is just a normal middle-aged man, right? 55 is still middle-aged, because when I get to 55, I want to say I'm middle-aged. So we do what every paramedic does. We put him on 12 lead. What do we notice?
Gonna say ST elevation in lead 3. Well, no, never mind.
Okay.
ST elevation V1, and it's a wider complex.
Okay. Is that elevation? It's a wide complex in what lead?
V1.
Okay. So V1.
And
what did I say about wide complexes in V1?
That it's most likely a bundle branch block.
Ah, it's most likely a bundle branch block. Which one?
So that's going to be a right bundle branch block.
How'd you figure that out? Because this is equal parts positive and negative.
Because it goes right at the J point.
Yeah. Come down the road backwards, I got to go right. Okay. Or what letter does it look like?
The M. R.
Could that explain him passing out?
Yes.
Absolutely could. I don't see, when you said elevation 3, I was like, please don't go down that road. There's no elevation anywhere. What we're seeing is a wide QRS complex. That's it. In lead V1. You can see the same thing in V2, same thing in V3. Nowhere else do I have depression. Nowhere else do I have elevation. How do you treat this guy? Said he's feeling a little nauseous. His blood pressure's a little low. He's scared. How do we treat him?
Give him some Zofran. Give him some fluids if his blood pressure's low, and just treat the symptoms.
Absolutely. If there's one thing I will pound into your guys' head, it's treat your patient. All right. Mr. Fulton, since I'm guessing you're on here now, right?
Yeah, I'm back.
Yeah. What do you see here? No scenario. Tell me what you see.
Depression in V2.
Depression where?
V2.
Okay, so depression in V2. Keep going.
Elevation in 1 or 2 and 3.
Okay.
And AVF.
Okay.
And then I want to say depression as well in AVR and AVL.
Okay. Remember, AVR is like a pointless lead. That doesn't even mean anything. Where else can we see depression?
V1 a little bit. Not really.
That's more just a T wave. How about lead 1?
Lead 1. Over in lead 1.
Okay. So I have elevation in what leads again?
2, 3 in AVF.
What part of the heart is that?
That's your interior part.
My what?
Inferior.
There you go. Now, what lead can I move over to double check to see if this is a right side MI?
Lead 4 or V4.
Yeah, move lead V4 over. No issues. Good job. I move V4 over. And now that's what I see in V4. Is that elevation?
Yes.
Absolutely, that's elevation. And that's literally how you label it on a 12 lead if you print it off. Once you print your normal one, keep that. Once you move your lead over, print it off, circle V4 and write V4R. So that way, when you show it to cardiology or bring it into the hospital, they know it's a reverse 12 lead. When in doubt, call a STEMI. If you're in doubt at all, call a STEMI. I'd rather have my butt chewed by a cardiologist or an ER doc than me second guess a patient and them get hurt because of how I misdiagnosed them. Barry, you on here?
Yep.
All right, tell me, call out what you see.
Elevation in 1, depression in 3, elevation in AVL, maybe depression in AVF, elevation in V2, V3, V4, V5, and V6.
Yikes. What's going on with this guy?
Anterolateral STEMI, except there's septal involvement too, I guess.
So, why is that showing up at the bottom there? Okay. Does anybody remember what I said when 3 vessels are involved, potentially? What that's called?
Widowmaker.
There you go. That's a perfect example of a widowmaker or three vessel disease. Because I have elevation in my lateral leads, I have elevation in my anterior leads, and I have depression in my inferior leads. Lateral and anterior look at 2 different parts of the artery. That's 2 totally different parts. So if I'm seeing elevation in both those, I have almost like total occlusion. This is a patient that you have time. I mean, you don't have time. Time is not on your side in this instance. This patient needs a cath lab, not us to sit around and go, you know what? I think I'm going to try nitro on you. I think I'm going to do that. I feel comfortable doing nitro. You like nitro? No, this is a patient you load and you say, hey, get me to the hospital safely and quickly. The best treatment you can give for this patient is a bolus of diesel fuel. Get to the hospital quickly, early notification to the hospital of what you have. Send a picture of this, whether you're using Pulsera, whether you're transmitting over your cardiac monitor. All right. How do I turn my camera on? I told you guys it'd be a short night. What questions can I answer for you? We have all the time in the world. Doesn't matter to me, but again, I'm gonna try to cut some of your classes short because I feel really bad about your first class that was 4 hours long. And I cannot, with cardiology, I can't make you guys sit here for 3 or 4 hours. It's not fair to you. You're really not going to retain any information when I do that, to be honest. Who feels pretty comfortable with ST elevation and ST depression?
I do.
Yeah.
Yeah, it's not hard. When we get into hard areas is like our bundle branch blocks, our axis deviation, and then our normal blocks, right? But remember, axis deviation, 2 thumbs. Do that every single time. Left thumb, if it can go upside down, it can go straight up and down. Right thumb can go upside down, straight up and down. Get in the habit of learning your regular blocks, your 1st degree, your 2nd degree type 1, your 2nd degree type 2, and your 3rd degree. And as well as bundle branch blocks. This is the bread and butter of what 12 leads are. There's nothing more that I'm going to teach you that's brand new to you about 12 leads. Next week, I'll go over some medical conditions, but there's nothing new you're going to learn. Now you take this base knowledge and you expand upon it. You talk to the people you work with. You look in EKG Made Easy books. You look at different 12 leads. You go to cardiology. I'm going to open up tomorrow. I'll open up cath lab and cath lab recovery for you guys. You can start doing clinicals there. They are great to be able to see how the heart functions and watch an angiogram in real time. Watch the heart pump, watch the dye go into our coronary arteries and watch and see where the blockage is. It's pretty damn cool if you've never seen one. There's nothing more you're going to learn that's crazy when it comes to 12 leads. Now we just build upon what we do know. Now we just expand our knowledge from what we do know. And we practice this every chance we can. Do a 12 lead every chance you can on a patient. I get it. It takes time. But I don't, we're paid by the hour. Do a 12 lead. Questions?
Can you put your little poem about the Winky blocks on D2L? Because every time I try to write it, you say it so fast I can't get it.
Yes, I will upload the
That'd be
poem.
awesome.
Or sing it. That'd be good. Just sing it on video and send it.
The COVID really took a toll on my throat. I can't sing.
Thank you. Yeah, you talk so fast at that point. I'm like, I can't write that fast. Sorry.
Yeah.
You had a patient that was on benzos. If you had a patient that was maxed out on benzos and they became non-med compliant, would that have a cardiac significance?
When you talk about non-med compliant, are you talking overtaking their meds or not taking
Nope,
them?
just cold turkey quit.
Not necessarily. More, you're going to see more cardiac for
Neuro.
potential benzo overdose
Okay.
instead of them just quitting cold turkey. What else? I'll answer any questions you guys got. I'll sit here for another hour and a half answering questions. Doesn't bother me.
Thank you for your time tonight.
Hey, not a problem. What I'm here for.
Hey, Rudy.
Yes, sir.
So in one of my introduction to EKG books I was reading, it's saying calcium plays a part in helping the AV node slow down electrical impulses. So could a calcium deficiency play a role too in like bradycardic kind of symptoms and everything?
It can, or we're going to get into that with because we've still got to cover cardiac emergencies, the rest of that chapter. And so we'll go over calcium deficiencies then.
I got you.
Anything else? So next week, we have to finish our cardiac emergencies chapter. I think it's around, I'm not going to lie to you guys, I think it's around 200 slides. A lot of it is basic knowledge. A lot of it's cardiac assessments. A lot of it's stuff we've covered already. I'm going to go through the slideshow and pick out the stuff that we've already done. And I'm going to throw some stuff in there that I feel is pertinent as well. But again, we've covered, we'll have covered cardiology for 6 weeks at this point, come next week. Am I saying that I expect you to know 100% everything about cardiology? No, I'm not. Am I expecting you to go out and study it? Absolutely, I am. Am I expecting you to look at EKG Made Easy books? Absolutely, I am. Look in your textbook. Look on YouTube. Again, like I said, another resource is Khan Academy. If you're not sure what that is, you can YouTube Khan Academy, and they have great resources for paramedic students. The resources are all there for you. It's if you choose to use them or not. I'm a resource as well. If you have questions about something, I'm generally really responsive to emails. I honestly, from Wednesday until today was my first day back at work, I tested positive for COVID last week. I was still at home responding to emails because that's my job. I don't want to leave you guys hanging. So I'm not going to leave it where if you guys have a question about something where we're just not going to cover it. So if you have something that maybe you don't bring up tonight or you forget about, or we end this class and you're like, God, I was going to bring this up, send it to me in an email. I'll reply to you. I might even call you if I think that talking to you on the phone might warrant a better explanation. Any other questions?